Hello, welcome to another session yet again of the Healthcare of the Clan 3 course. We began our discussion on reproduction 2 weeks ago. During the last session, we discussed normal pregnancy and adaptations of the mother to pregnancy. Make sure that you have reviewed the PowerPoint for gestational and pre-existing conditions before spending time on this topic. Once a provider determines that a pregnancy or a pregnant client has risk factors that can affect a healthy pregnancy, he or she has to initiate close monitoring and assessment to prevent fetal demise and ensure maternal well-being. Risk categories that can adversely affect pregnancy include biophysical risk, such as malnourishment and obesity. Because the pregnant mother needs adequate folic acid and proteins for fetal development, malnourishment can decrease intrauterine growth and put the fetus at risk for premature birth. Obesity, on the other hand, contributes to gestational conditions such as hypertension and gestational diabetes. Diabetes contributes to fetuses becoming larger than the gestational age, which can cause complications during birthing process. Another category is medical or obstetric-related illness. Medical illness are pre-existing conditions such as hypertension, seizures, or diabetes. Examples of gestational conditions are preeclampsia, eclampsia, gestational diabetes, antepartum bleeding such as placenta previa and placenta abruption. The pregnant client will also be monitored closely if any psychosocial risks exist in relation to maternal behaviors and lifestyle. The presence of abuse, whether interpersonal violence, partner abuse, or emotional distress related to pregnancy, especially if the pregnancy was unplanned or the client is unpartnered and probably doesn't have the support of her family, can create self-care deficit and potential harm to the mother as well as the fetus. Substance abuse is also a major cause of high-risk pregnancy. Substances such as cigarette smoking and use of IV drugs such as methamphetamine, cocaine can contribute to decrease intrauterine growth, leading to low birth weight. Opioid abuse will also cause the fetus to become dependent and have withdrawal syndrome at birth. There are other socio-demographic risks that has to be considered. Socio-demographic factors such as low income, which may limit access to healthcare, teenage pregnancy, and pregnancy at older age above 35 years all can contribute to pregnancy complications. In addition to all the risk factors we have discussed, environmental hazards from the workplace, such as if the client works in an area with radiation or chemicals such as chemotherapy agents, can cause genetic defects and affect the pregnancy adversely. Working in a high temperature area can also affect the pregnancy. Infections and pollutants can also adversely impact the pregnant mother as well as the fetus. All these factors will contribute to one of the following high-risk pregnancy problems. The first one is polyhydramnios. Causes include poorly controlled diabetes, fetal-maternal bleeding, fetal congenital anomalies, example gastrointestinal obstruction, and CNS abnormalities. Genetic disorders and twin transfusion syndrome are examples of what can cause polyhydramnios. Polyhydramnios is an increase in the amount of amniotic fluid. The second problem is intrauterine growth restriction. Maternal causes include hypertensive disorders such as pre-gestational hypertension. Also, pre-gestational diabetes can also contribute to this. And then cyanotic heart disease of the fetus can also contribute to this. Autoimmune disease, restrictive pulmonary disease, multifetal gestation, malabsorptive disease or malnutrition, and living in a high altitude area with tobacco abuse or substance abuse can all contribute to intrauterine growth restriction. Fetal causes include genetic disorders such as teratogenic exposures or exposure to cancer and fetal infection. Then the third problem that can result is oligohydramnios, which is inadequate amniotic fluid. And this can be as a result of renal agenesis, which is also known as Potter's syndrome, premature rupture of membranes, prolonged pregnancy, uteroplacental insufficiency, which means that the fetus or the placenta is not perfusing to get adequate perfusion to the fetus. And then severe intrauterine growth restriction, which can be caused by multiple factors such as drug use, malnutrition, and all the other factors that we have talked about. And maternal hypertensive disorders. Maternal dehydration as well as hypovolemia will also cause oligohydramnios. And lastly, chromosomal abnormalities. These contribute to chromosomal abnormalities, and they include advanced maternal age such as greater than 35 years of age, parental chromosomal rearrangement, and previous pregnancy with autosomal trisomy. Once a pregnancy has been identified as high risk, the pregnant woman and her fetus are monitored carefully throughout the remainder of the pregnancy. There are various antenatal assessments and testing available to ensure that both the fetus and the mother are in healthy conditions when any of the problems that we have talked about exist. This usually includes a biophysical assessment, sometimes known as the biophysical profile. Assessments in a biophysical profile include intrauterine assessment of the fetus and imaging to determine fetal breathing, movement, muscle tone, reactivity to stress using the fetal heart rate monitor, and amniotic fluid volume. Each of these components are scored on a 0 to 2 scale and totaled up to 10 points. A score of 8 out of 10 or greater is considered normal. We will take each of these components and discuss it in the subsequent slides. But first, let's talk about daily fetal movement. Daily fetal movement count or kick count is a non-invasive, or inexpensive, simple to understand and yet valuable method for monitoring the movement of the fetus. Fetal kick count is assessed by the pregnant mother and can be done by either counting all movements by the fetus once a day for 60 minutes or 2 or 3 times daily, especially after meals or before bedtime for 2 hours or until 10 movements are counted. The last method is to count all fetal movements in a 12-hour period each day until a minimum of 10 movements are counted. The mother records the movements on a data sheet and report them to the provider. The fetus requires further assessment with a stress test if one of the following conditions exist. 1. If no movement within 12 hours or the so-called fetal alarm signal occurs. And 2. If the mother counts less than 3 fetal movements within 1 hour. It is very important for the nurse to educate the pregnant client about what is meant if fetal kicks are present or absent, and when to notify the healthcare provider. So if there are no fetal counts, the nurse should educate the client as to what to do or the steps to take. The nurse should also note that obese patients may have reduced ability to feel fetal movements, and it may be reduced temporarily if the woman is taking depressant medications, drinking alcohol, or smoking cigarettes. Also, fetal movement may not present if the fetus is sleeping, so ask the mother to count cake at another time, especially after a meal. This is a sample data sheet for collecting fetal counts. The other component of antenatal assessment is ultrasonography. The ultrasound visualizes the fetus, placenta, amniotic fluid, and it is the most common and valuable diagnostic tool used in obstetrics here in the United States. It provides critical information about the health care of the patient as well as the fetus, and give critical information to the healthcare providers regarding fetal activity and gestational age, normal versus abnormal fetal growth curves, fetal and placental anatomy, as well as fetal well-being and visual assistance with which invasive tests can be performed more safely, such as in amniocentesis. Another benefit of ultrasound is to perform a Doppler blood flow analysis to estimate placental sufficiency, or in other terms, to determine if the fetus has adequate blood supply. Fetal images from ultrasound is a positive sign for pregnancy, and as such, it is also used to confirm pregnancy. See Table 10.1 in your textbook for the major uses of ultrasound in pregnancy. When a client is undergoing ultrasonography, you as the nurse will have to educate the client to drink a lot of fluid and avoid emptying her bladder prior to the ultrasound testing. So this is an example of an image using the ultrasound. There are various images that can be developed, including 3D and 4D images. During the biophysical assessment, a magnetic resonance imaging can also be obtained. Magnetic resonance imaging is a non-invasive radiologic technique used for obstetric and gynecologic diagnosis. The MRI does not use ionized radiation, therefore it is mainly considered safe, but provides excellent pictures of soft tissues. With the MRI, the examiner can evaluate fetal structures such as the central nervous system, the thorax, abdomen, genitourinary tract, musculoskeletal system, and overall growth, the placenta position, density, and presence of gestational trophoblastic disease, and the quantity of amniotic fluid as well. The quantity of amniotic fluid as well. Maternal structures such as the uterus, cervix, and also the pelvis can also be assessed using the MRI, and the biochemical status of tissues and organs can also be determined using the MRI. So this has multiple functions because it can be used to determine functional anomalies and can be also used to evaluate other metabolic conditions that may be present in the fetus. Another component that is present with biochemical assessment is amniocentesis. So amniocentesis forms part of the biochemical analysis during pregnancy. In amniocentesis, amniotic fluid is aspirated using a needle inserted through the abdomen and uterine walls. It is performed using ultrasound as an adjunct to guide and prevent fetal injury. It is performed between 14 to 17 weeks of gestation and can be used for diagnosing chromosomal abnormalities, inborn errors of metabolism, neural tube defects such as spinal bifida or encephaly, and also determining lung maturity. It can also be used to determine fetal sex and X-linked disorders. However, there is a high risk associated with amniocentesis and should be indicated only if there is a high risk for the clients, such as older maternal age, which is greater than 35 years of age or older, older paternal age, although there is no consensus about this, but it's usually considered to be greater than 40 to 50 years. Parents who are affected by or are carriers of genetic disorders including sickle cell anemia that we have talked about, Tay-Sachs disease, and cystic fibrosis should be recommended to undergo amniocentesis. Also, because of the risk associated with amniocentesis, women with a proud child with a structural birth defect or with a structural fetal defect identified by ultrasound can be recommended to undergo amniocentesis for their current pregnancy. And women with a proud child with chromosomal abnormalities may also be recommended to undergo amniocentesis. There are various complications that are associated with amniocentesis. Maternal complications usually occur after the procedure and include leakage of amniotic fluid, hemorrhage, fetal-maternal hemorrhage, which is bleeding internally between the fetus and the mother, with possible maternal Rh isoimmunization. So if the mother is Rh positive and the baby is not, then there are risk of bleeding if the baby is introduced to the Rh positive antibodies. Also, infection and preterm labor can also result from amniocentesis, and then placental abruption or inadvertent damage to the intestines or bladder can also occur, with amniotic fluid embolism also possible. So because of all these all these complications, that is why we don't just do amniocentesis on just about every pregnant woman. There are also some fetal complications that can occur with amniocentesis, and these are as follows. The fetus can suffer death, hemorrhage, infection, which is caused by the amniotic fluid becoming infected, and direct injury from the needle, such as the removal of a tissue that is going to develop into some body parts. Nursing considerations before the procedure should include obtaining written consent, because this is an invasive procedure. So just as you obtain surgical consent for every procedure, you're also going to obtain a consent for this procedure. Educate the client about the risk of fetus and mother complications. Because of the possibility of fetal-maternal hemorrhage, the nurse should assess if the mother is Rh negative and educate her about the RhoGAM or the Rho-D immunoglobulin administration after amniocentesis. Ask the client to empty bladder prior to the procedure to avoid bladder puncture. So whereas in ultrasound you encourage them to keep a full bladder, with amniocentesis you are going to ask them to empty their bladder. After the procedure, the nurse will have to monitor for signs and symptoms of hemorrhage, signs of preterm labor, premature separation of the placenta, fetal distress, amniotic fluid embolism, and monitor for any signs of fluid loss in the immediate post-procedure time. The nurse will also have to monitor and educate the client to report signs and symptoms of infection, such as high fever. Injury to the intestines and bladder should also be monitored, and this will be indicated by peritonitis, which can occur as a result of the leaking of bowel content or urine into the peritoneum. And then the nurse will have to monitor for subsequent injury to the fetus. This is not normally determined and may be found out with ultrasonography some weeks after this procedure, or even it may occur after the child has been born. One other test that can be used in the biochemical assessment is chorionic villus sampling, and this is similar to amniocentesis, but there are some differences also between this. This is performed in the first or second trimester, ideally between 10 to 13 weeks of gestation, and involves the removal of a small tissue specimen from the fetal portion of the placenta. The specimen is obtained transcervically or transabdominally, so this means that they can go through the cervix or through the abdomen to obtain the tissue, and this is normally done under the guidance of an ultrasound. The transabdominal approach is preferred only if genital herpes or cervicitis is present. So if the mother has genital herpes, or if there is any inflammation of the cervix, then the abdomen is going to be the choice, but it is normally done transcervically, that is through the cervix. So this is a picture of how the CVS is done. I'm going through the cervix. Okay, so the transabdominal approach is preferred only if genital herpes or cervicitis is present, as I mentioned, and this is done with a needle going through the abdominal wall and through the uterine wall into the intrauterine environment to get a sample tissue from the developing fetus. The risks include intrauterine growth restriction and reduced fetal limb, in addition to all the complications associated with amniocentesis. So because we are getting a tissue from the baby, we might end up getting a tissue that has to develop into the limb, and that is what is called the limb restriction. So nursing considerations. Nursing considerations include pre-procedure and post-procedure care, which is similar to what the nurse would do for a client undergoing amniocentesis. The nurse should also ask the client to keep a full bladder when the transcervical method is used. Percutaneous umbilical blood sampling is another biochemical assessment that can be performed. The percutaneous umbilical blood sampling involves the insertion of a needle directly into a fetal umbilical vessel, preferably the vein, under ultrasound guidance. The percutaneous umbilical blood sampling can be used for fetal blood sampling and also for transfusion to the fetus. However, this procedure has been replaced in many centers by placental biopsy because it is safer and easier and faster to achieve. The most common genetic indication for the use of the PUBS PAPS is evaluation of mosaic results found on amniocentesis, or CVS, when a sample of fetal blood is required to determine the specific mutation for the genetic disorder. And so this is how that is done. PAPS is also used to assess for fetal anemia and also for conditions such as infection and thrombocytopenia. Bleeding from the cord puncture site is the most common complication of the procedure, and transient fetal bradycardia can also occur. Maternal complications are amnionitis and transplacental hemorrhage that can also occur with this procedure. Then you have the maternal assays, which is included in the biochemical assessment, and this includes the alpha phenylprotein. The maternal serum alpha phenylprotein levels are used as a screening tool for neural tube defects in pregnancy between 15 weeks and 20 weeks of gestation. Through this technique, approximately 80% to 85% of all open neural tube defects and open abdominal wall defects can be detected early. Screening is recommended for all pregnant women because this is just obtaining a blood sample from the woman. We also have the multiple marker screen and screening to detect fetal chromosomal abnormalities, particularly trisomy 21, which causes Down syndrome, is available beginning at 11 to 14 weeks of gestation. In the presence of a fetus with trisomy 21, the HCG levels and the NT measurement are higher than normal in the first trimester. A Coombs test is also a screening tool that is used for Rh incompatibility. If the maternal titer for Rh antibodies is greater than 1 or is greater than a 1:8 ratio with amniocentesis is used for determination of the amount of bilirubin in the amniotic fluid, and this is indicated to establish the severity of fetal hemolytic anemia. So if you obtain a result that is 1 to 8, then you know that there is some hemolytic disorders going on. There is also another biochemical test that can be done, and this is called the cell-free DNA in maternal blood. So remember when we talked about genetics, I said the Human Genome Project has improved the testing in pregnancy, and this is one of the results from that. Cell-free DNA in maternal blood is a new non-invasive screening tool made possible by advances in the Human Genome Project. It is used for the detection of fetal chromosomal abnormalities and is performed at 10 to 12 weeks of gestation. This can also be used for determining fetal Rh status and fetal gender, and also paternally transmitted single gene disorders. The cell-free DNA test is simple to perform, and it is just done by a sample of maternal blood, which is obtained by venipuncture and sent to a commercial lab for analysis. It works by amplifying cell-free DNA, and women with positive cell-free DNA results are referred to for amniocentesis or CVS to confirm the findings. So this eliminates putting the mother at risk and the fetus at risk for amniocentesis, because it helps us to definitely determine if it is necessary for amniocentesis or CVS to be performed. There are also electronic fetal monitoring that can be used, and that can be a form of a diagnostic tool to determine fetal well-being. So used to evaluate fetal, it is used to evaluate the fetal heart rate by electronic fetal monitor in response to fetal stimulation and movement. You have the non-stress test that can be performed as early as 27 weeks. And when you are performing the non-stress test, you can provide a snack during the procedure because fetal activity increases after ingestion of food due to increased glucose availability. The pregnant client should eat about 2 hours before the procedure, and if the fetus is in the sleep cycle or sleeping, vibroacoustic stimulation can be used to increase fetal response, and this is done or is achieved by using vibrating sound, usually from a laryngeal stimulator, on the maternal abdomen or over the fetal head for 3 seconds, and it can be repeated in 1 minute intervals for up to 3 minutes to determine if the fetus is going to react to the stimulation or not. The test can be classified as reactive or non-reactive, and a reactive test is when there are 2 accelerations in a 20-minute period, each lasting at least 15 seconds and peaking at least 15 beats per minute above the baseline. So you will establish a baseline heart rate, and then after the stimulation, then you are going to assess to see if the heart rate will rise above the baseline at least 15 beats per minute. So if the baseline was 120, then you expect the heart rate to go above 135, which will be the 15 beats per minute increase, and it should last for at least 15 seconds. Before 32 weeks of gestation, an acceleration is defined as a rise of at least 10 beats per minute, lasting at least 10 seconds from the baseline. So if the pregnancy is less than 32 weeks, then instead of 15 for 15 seconds, it will be 10 beats per minute for 10 seconds. Fetal heart rate accelerates 15 beats per minute or more than the baseline, lasting 15 seconds or more, with at least 2 fetal movements in a 20-minute period for it to be considered as reactive. So, a non-reactive test, therefore, is a test that does not demonstrate at least 2 qualifying accelerations, which is the increase in heart rate for 15 beats per minute, and also there is no increased heart rate within a 20-minute window, and there is no noticeable accelerations, or the accelerations do not increase by at least 15 beats per minute. So it's basically the opposite of a reactive test. And you can see on the slide where there is no reactivity, because this heart rate is still hovering around 130, and so there is no actual increase in the heart rate. A non-stress test is considered satisfactory if there is inadequate fetal movement despite snacks, gentle pushing on the fundus, or vibroacoustic stimulation. This will mean that the test will have to be repeated and will have to be done again at a different time. If a non-stress test is unsatisfactory, non-reactive, or if it is satisfactory but the provider wants more concrete information or assessment, then a contraction stress test is going to be ordered. The contraction stress test provides an earlier warning of fetal compromise than the non-stress test and produces fewer false positive results. Like most methods of antepartum fetal surveillance, however, it cannot predict acute fetal compromise, example, umbilical cord accident or placenta abruption, or rapid deterioration of glucose control in a woman with diabetes. The contraction stress test is more time-consuming and expensive than the non-stress test. It is also an invasive procedure if oxytocin stimulation is required instead of this nipple stimulation. In general, the contraction stress test cannot be performed on women who should not give birth vaginally at the time, or who cannot give birth vaginally at the time the test is done. Absolute contraindications for the contraction stress test are the following: a history of preterm labor, or if the patient is in preterm labor; placenta previa, if there is also cervical insufficiency; multiple gestation; and previous classic uterine incision for cesarean birth, which is a longitudinal incision for cesarean birth. There are 2 main forms of the contraction stress test. Number 1 is the nipple stimulated contraction test, where the pregnant mother stimulates or massages the one nipple for at least 10 minutes. And then you also have the oxytocin stimulated contraction test. And this is done by an intravenous or IV infusion of oxytocin, and is normally done by using a dilute solution of oxytocin, which is 30 units in 500 cc's of normal saline, or in D5 normal saline. Interpretations of the stress test will determine how well the fetus is doing. So if the results are obtained, then the nurse will have to be able to interpret to determine if the test was negative, if it was positive, if it was suspicious or equivocal, or if it was unsatisfactory. So we are going to take each of these to kind of look at them and one by one. So if a test is negative, then it means that at least 3 uterine contractions in a 10-minute period occurred with no late or significant variable decelerations. So in the non-stress test, we were looking for accelerations. In the contraction stress test, we are looking for decelerations, because decelerations indicate placental insufficiency and the lack of oxygenation to the fetus. If the test is negative, then usually we will resume our routine weekly testing schedule. A positive test occurs when there are late decelerations occurring with 50% or more of the contractions, even if there are fewer than 3 contractions in 10 minutes. So if there is 50% decelerations that is occurring in the heart rate of the infant or the fetus, then it means that the contraction stress test is positive. And usually this warrants hospital admission for further evaluation or for continuous monitoring and evaluation for the possibility of delivery of the fetus if they have reached the gestational stage where they can be successfully delivered for them to survive out of the intrauterine environment. If the test is suspicious or equivocal, then it means that there are prolonged variable or late decelerations occurring with less than 50% of the contractions, and this will mean that further evaluation is needed either by prolonged monitoring or repeat the testing the next day. On the other hand, if the test is classified as equivocal hyperstimulatory, then this means that decelerations are occurring in the presence of contractions are more frequent than every 2 minutes or lasting longer than 90 seconds. And this will warrant further evaluation either by prolonged monitoring or repeated testing on the next day. So that is similar to the suspicious or equivocal test results. Then last, if the test is considered as unsatisfactory, it means that the test failed to produce 3 contractions within a 10-minute window, or there is an inability to trace the fetal heart rate. And this will require further evaluation either by prolonged monitoring or repeated testing the next day. So these test results are important because it tells us how the fetus is doing and if we need to deliver the baby, or if the baby can be, or the fetus can be monitored for some time to see if they will regain their well-being or if there is no immediate harm to them. The nurse's role in antepartal or antepartal assessment is for the nurse to educate the patient and also support the individual undergoing the testing by providing adequate support systems and resources. Also, the nurse will have to assist the physician with the procedures such as positioning the patient for the amniocentesis and the CVS. In some areas, the nurse will perform the non-stress test and the contraction stress test and interpret the results and communicate that to the provider, so the provider will take note and also intervene. The nurse will also have to perform the initial assessment before the procedure, so determining the well-being of the fetus by doing the measurements of the fundus and all that, and also communicating that with the provider so that there can be a collaborative response to the client's condition. So thank you for listening to this presentation. I hope this helps you to organize your learning. We will talk more about these conditions and testing in class as we do the in-class activities. If you have any questions, you can email me or write down your questions and we will talk about them in class.